Department of Medicine, Manipal College of Medical Sciences. Cor Pulmonale. Aloxina. Department of Medicine, Manipal College of Medical Sciences. Pokhara, Nepal. Right-sided heart disease secondary to lung disease. Cor pulmonale is defined as an alteration in the structure and function of the right ventricle caused by a primary disorder of the respiratory system, lung parenchyma, lung vasculature or thoracic cage. Right-sided heart disease secondary to lung disease. Pulmonary hypertension is the common link between lung dysfunction and the heart in cor pulmonale. Pathophysiology. 1. Pulmonary vasoconstriction due to A. Hypoxia. B. Blood acidemia. 2. Obliteration of the pulmonary vascular bed secondary to lung disorders. A. Emphysema. B. Pulmonary thromboembolism. C. Interstitial lung disease. 3. Increased blood viscosity secondary to blood disorders. Polycythemia vera. Sickle cell disease. Macroglobulinemia. 4. Idiopathic primary pulmonary hypertension. Decreased LV volume, decreased coronary. Pulmonary pressure, dilatation of RV, reduced CO and septal displacement. Decreased LV volume, decreased coronary. Blood to RV, further deterioration of RV. Function. Septum pushed to left. Reversed Bern-Mames effect, patient with acute pulmonary hypertension. Due to pulmonary embolism. After clot lysis. Acute cor pulmonale. Massive pulmonary embolism, more common. B. Acute respiratory distress syndrome, ARDS. Is associated with RV dilatation. Chronic cor pulmonale. COPD greater than 50% of cases. Disorders with primary involvement of pulmonary vasculature and circulation. Repeated pulmonary emboly. Pulmonary vasculitis. Pulmonary veno-occlusive disease. Sickle cell disease. High-altitude disease with pulmonary vasoconstriction. Primary pulmonary hypertension. Disorders with secondary involvement of pulmonary vasculature and circulation. Parenchymal lung diseases. Chronic obstructive pulmonary diseases. Interstitial lung diseases. Neuromuscular disorders. Myasthenia gravis. Poliomyelitis. Amyotrophic lateral sclerosis. Obstructive and central sleep apnea. Thoracic deformities. Kyphoscoliosis. Ankylosing spondylitis, clinical features. Clinical manifestations of cor pulmonale not specific. Symptoms subtle in early stages of the disease mistakenly attributed to underlying pulmonary pathology, which are easy fatigability, tachypnea, exertional dyspnea, cough, followed by because of rupture of a dilated or atherosclerotic pulmonary artery. 1. Anginal chest pain. Right ventricular ischemia, does not respond to nitrates. Right coronary artery stretching and dilated AV groove following RVH. 2. Hemoptysis. Because of rupture of a dilated or atherosclerotic pulmonary artery. 3. A variety of neurologic symptoms may be seen due to decreased cardiac output and hypoxemia. Impaired cognitive and higher mental functions. The left recurrent laryngeal nerve by a dilated pulmonary artery. 4. Rarely hoarseness due to compression of the left recurrent laryngeal nerve by a dilated pulmonary artery. 5. In advanced stages, passive hepatic congestion secondary to severe right ventricular failure lead to anorexia. Right upper quadrant abdominal discomfort. Jaundice. 6. Syncope with exertion seen in severe disease. reflects a relative inability to increase cardiac output during exercise with a subsequent drop in the systemic arterial pressure. 7. Peripheral edema, physical findings. May reflect a. The underlying lung disease. b. Pulmonary hypertension. c. RVH. d. RV failure. On inspection: 1. An increase in chest diameter. 2. Labored respiratory efforts with retractions of chest wall. 3. Distended neck veins with prominent A or giant V waves. 4. Cyanosis may be seen, RVH, characterized by epigastric pulsation, left parasternal heave, apex beat, in fifth ICS outside MCL diffuse, Al-Swattained, plus hepatojugular reflex and pulsatal liver are signs of RV failure with systemic venous congestion. On percussion, hyperresonance of the lungs may be a sign of underlying COPD. Ascites seen in severe disease. On auscultation of the chest, wheezes and crackles, signs of underlying lung disease. In early stages: 1. Splitting of the S2. 2. Loud P2. In advanced disease 2. Followed by ejection systolic murmur. 1. Sharp ejection click, single or multiple, over the pulmonary artery. 2. Followed by ejection systolic murmur. 3. Later on, diastolic pulmonary regurgitation murmur, Graham-Steele. 4. Maybe S3 and/or S4. 5. Systolic murmur of tricuspid regurgitation. Differential diagnosis: congestive, biventricular, heart failure. Primary pulmonic stenosis. Primary pulmonary hypertension. Right-sided heart failure due to congenital heart diseases. Right heart failure due to right ventricular infarction. Investigations. Routine investigation. Hematocrit. Greater than 50 polycythemia. Greater than 60, indication for phlebotomy. To confirm diagnosis: ECG, X-ray, chest echocardiography. Right heart catheterization, ECG and Cor Pulmonale. Electrocardiography, ECG. RVH or RV strain. A. Right axis deviation. B. RS amplitude ratio in V1 greater than 1, RS amplitude ratio in V6 less than 1. C. P pulmonale increase in P wave amplitude in leads 2, 3, and AVF. D. Incomplete or complete right bundle branch block, RBB, especially if pulmonary embolism is the underlying etiology. E. Low voltage QRS because of underlying COPD with hyperinflation and increased AP diameter of the chest. Chest rentgenography. Enlargement of the central pulmonary arteries with oligemic peripheral lung feldspar. Pruning. Right descending pulmonary artery greater than 16 mm. Left pulmonary artery greater than 18 mm in diameter. RVH. Elevated brain natriuretic peptide, BNP, level. Earliest evidence of CCF. A natural mechanism to compensate for elevated pulmonary hypertension and right heart failure by a. Promoting diuresis and natriuresis. b. Vasodilating systemic and pulmonary vessels. Arterial blood gas tests provide important information about the level of oxygenation and type of acid-base disorder, to know the etiology PFT to confirm underlying lung disease. To exclude pulmonary thromboembolism. Ventilation/perfusion, VQ, scan or CT chest. Hypercoagulability states evaluated by levels of protein C and S, antithrombin 3, factor V Leiden, antinuclear antibody, ANA, level for collagen vascular disease such as scleroderma, serum alpha-1 antitrypsin. Management. Oxygen therapy, diuretics, vasodilators, digitalis, anticoagulation therapy are all different modalities used in the long-term management of chronic cor pulmonale. Long-term oxygen therapy can be considered even if PaO2 is greater than 55 mm Hg or O2 saturation is greater than 88%. Because of vasodilator effect on pulmonary arteries. Diuretics right ventricular filling volume markedly elevated. Diuretics may result in improvement of function of both the right and left ventricles. Adverse effects. A. Excessive volume depletion can lead to a decline in cardiac output. B. Hypokalemic metabolic alkalosis lead to cardiac arrhythmia. Diuretics needs to be used with caution. Vasodilator drugs in long-term management of chronic cor pulmonale have modest results. 1. Calcium channel blockers. Oral sustained-release nifedipine. Diltiazem. 2. Beta blockers. 3. Nitrates. 4. Angiotensin-converting enzyme, ACE, inhibitors. Not routinely used. A trial of vasodilator therapy considered in patients with COPD with disproportionately high pulmonary blood pressure, more than 40 mm Hg. Newer vasodilators endothelin receptor antagonist. Bosentan. Prostacyclin PGI2 analogs. Epiprostanol I.V. Iloprost, MDI. They have shown a promising effect in reducing the pulmonary hypertension. Cardiac glycosides not routinely indicated. Beneficial effect not as obvious as in LVF. Modest effect of digitalis on failing right ventricle and chronic cor pulmonale. Must be used cautiously. Should not be used during the acute phases of respiratory insufficiency. Patients with hypoxemia or acidosis are at increased risk of developing arrhythmias. Theophylline bronchodilatory effect. Reduce pulmonary vascular resistance and pulmonary arterial pressures. Weaken atropic effect and thus may improve right and left ventricular ejection. Strengthens diaphragm. Stimulates the respiratory center.